Anxiety disorders are the most common class of mental health conditions in the world, affecting roughly 1 in 3 people at some point in their lifetime. Yet anxiety itself is not pathological. It is an evolutionary gift. The distinction between healthy anxiety and disorder lies not in the presence of fear, but in its proportion to actual threat, its duration, and how much it interferes with functioning. Generalized anxiety disorder, or GAD, is characterized by excessive, uncontrollable worry that spans multiple life domains: health, finances, relationships, work, world events, for at least 6 months. The worry is difficult to control, even when the person recognizes it is disproportionate. GAD is accompanied by physical symptoms including muscle tension, fatigue, irritability, concentration difficulties, and sleep disruption. Unlike specific phobia, which focuses on a particular trigger, GAD is free-floating. The anxiety is always present, searching for a new topic when the current one is resolved. Specific phobias are intense, persistent fears of particular objects or situations that are out of proportion to the actual danger. The 4 major categories are animal phobias, natural environment phobias like heights and storms, blood injection injury phobias, and situational phobias like flying or enclosed spaces. The defining feature is that the person recognizes the fear is excessive yet cannot control it, and they go to significant lengths to avoid the feared object or situation. The avoidance is the behavior that maintains the phobia by preventing the extinction of fear. Panic disorder is diagnosed when a person experiences recurrent, unexpected panic attacks, sudden surges of intense fear that peak within minutes and include physical symptoms like racing heart, shortness of breath, chest pain, dizziness, and tingling. Critically, panic disorder is not just about having panic attacks. It requires persistent worry about future attacks or significant behavioral changes to avoid having them, such as not going to public places. The physical symptoms of panic attacks can be so severe that the majority of people having their first attack go to the emergency room believing they are having a heart attack. Social anxiety disorder, formerly called social phobia, involves intense fear of social situations in which the person might be scrutinized, evaluated, or embarrassed. The core fear is acting in a way that will result in humiliation or rejection. This goes far beyond shyness. The anxiety is severe enough to cause significant avoidance of social situations, including public speaking, eating in front of others, or participating in conversations. Social anxiety disorder typically begins in adolescence and, if untreated, tends to persist into adulthood. It is the 3rd most common mental disorder worldwide. The biopsychosocial model proposes that anxiety disorders arise from the interaction of 3 sets of factors. Biological factors include genetic predisposition. Anxiety disorders run in families with heritability estimates around 30 to 40%, and temperamental traits like behavioral inhibition that increase vulnerability. Psychological factors include conditioning experiences, a dog bite that generalizes to all dogs, and cognitive patterns like catastrophizing and intolerance of uncertainty. Social factors include exposure to trauma, overprotective parenting that limits coping experience, and cultural contexts that normalize or stigmatize anxiety. Post-traumatic stress disorder develops after exposure to a traumatic event involving threatened death, serious injury, or sexual violence, either direct experience, witnessing, or learning about a close person's trauma. The 4 symptom clusters are intrusions, flashbacks, nightmares, distressing memories, avoidance of trauma-related stimuli, negative alterations in cognition and mood including shame, guilt, and persistent negative beliefs about the world, and hyperarousal including exaggerated startle, hypervigilance, and sleep disturbance. PTSD affects approximately 20% of people after serious trauma. The amygdala, an almond-shaped structure deep in the temporal lobe, plays a central role in threat detection and fear conditioning. It rapidly appraises incoming sensory information for threat, sometimes before the information reaches conscious awareness, and orchestrates the fear response. Neuroimaging studies consistently find hyperactivated amygdalae in people with anxiety disorders, responding more strongly and broadly to threat-related stimuli. The prefrontal cortex normally regulates amygdala activity through top-down inhibition, and disrupted prefrontal amygdala connectivity, is a consistent finding in anxiety disorders. Cognitive behavioral therapy is the most empirically supported psychological treatment for anxiety disorders across the board. CBT for anxiety has two main components. The cognitive component identifies and restructures catastrophic, probability overestimating, and consequence magnifying thoughts. The behavioral component, exposure, systematically confronts the feared object or situation in a gradual hierarchy without avoidance, preventing the safety behaviors that maintain anxiety. Meta-analyses consistently show that CBT produces response rates of 50 to 70%, with low relapse rates compared to medication alone. Exposure therapy is the most critical behavioral component in anxiety treatment. The therapist creates a hierarchy of feared situations from least to most anxiety-provoking, and the patient works up the hierarchy systematically, remaining in contact with each level until anxiety habituates, a process called extinction. Prolonged exposure, used for PTSD, involves repeated recounting of traumatic memories until they lose their emotional charge. The key mechanism is inhibitory learning. The patient learns a new, non-threatening association with the feared stimulus that competes with and gradually overrides the old fear association. Medications for anxiety disorders fall into two broad categories. Selective serotonin reuptake inhibitors, or SSRIs, are the first-line pharmacological treatment. They take 2 to 4 weeks to reach full effect, but have low addiction potential and moderate to strong efficacy. Benzodiazepines, like diazepam and lorazepam, provide rapid relief within minutes and are highly effective for acute anxiety, but they cause dependence, interfere with extinction learning, and are associated with rebound anxiety. Best outcomes are typically achieved with CBT combined with SSRI medication, which produces better long-term outcomes than either alone. Anxiety disorders are treatable, but they are also among the most undertreated of all mental health conditions. The same avoidance that maintains the disorder also keeps people from seeking help. Understanding the science of anxiety, that it arises from a miscalibrated threat system, not weakness, and that evidence-based treatments reliably correct that miscalibration, is itself part of the treatment.